Welcome to part 2 of Indirect Restorations for dental students, but it's actually suitable for all dentists. But the person who's asking all the questions is our Protrusive student, Emma Hutchison. Students are so curious and so great at asking questions, and I wanted to make sure that we tailor these more basic episodes to what actually students, young dentists, and those return to dentistry actually need. In part 1 of this series, we covered what are the different types of crowns that we might go through. In part 1 of the series, we discussed direct versus indirect, and when we are choosing indirect, which materials can we opt for? Especially focusing on all ceramic restorations, which from my time were not done that much as a student. We did PFMs, and it sounds like PFMs are still being done in dental schools. Let me tell you, PFMs are not done that much in the real world. So that's why we focus a lot on all ceramics. We also discussed on crowns versus onlay. So that was in part 1. In today's part 2, we're talking about the clinical details. When you get the crown back, how do you assess if this is a good crown or a bad crown? When should you reject? What are the different parameters that we tick off? And how can we avoid mistakes from happening so you never have to reject lab work? I'll give you a clue. It involves communicating with your lab technician. So important. Another interesting thing we discuss is what about if you try in a crown and it's completely shy of the bite? So it's not proud, it's not propping the patient open, it's not like, it's too big, it's actually completely shy of the bite. Should we reject that? Should we accept it? What is the standard of care? So we cover this real world scenario and so much more in this episode. So I hope you enjoy. Please do comment below and give us a like if you like what we do. I'll catch you in the outro. Emma Hutchison, welcome back again to the podcast student version. Just give us an update in terms of what's been happening in your world. Are things getting a little bit heated academically? Are you feeling the strain? Are you feeling the pressure?
Yeah, I'm really starting to. So at the moment, we're in sort of the end of February when we're recording this. And I'm just becoming, a bit more aware. Exams probably end of April, start of May time. So it's in the back of my mind, definitely. So really starting to keep on track of everything, keep up to date. So it's at this point in the year where it can really just make or break you, the workload and things, and just trying to keep on top of it and try your best not to be overwhelmed, which is so much easier said than done. But it's just, especially things like OSCEs as well. I think that's it's a different level of
Just
stress.
describe what OSCEs are to an international dental student maybe who doesn't know what an OSCE is, or maybe it's called something else in their country. What's an OSCE?
Yeah, so your OSCEs are like what does it stand for again?
Objective Structured Clinical Examination.
Yeah, that's the one. So you go in this big room and there's maybe, I think we have 12 stations. We've got 6 minutes per station. You go around and it's very much about your clinical knowledge, your hands-on work, your ability to communicate. They get actors in, like proper actors that they hire and things and that they pay. And they're very good. Yeah, very realistic patient scenarios. And it's all about communication and, less about, how you do in written exams and more about how you are as a person and how you are clinically. So it's a whole different type of stress that I had never felt before. And it's a hard one to get used to, but it's definitely something that you can learn, a skill that you can learn how to manage, I suppose.
Absolutely. Have you done any OSCEs before?
I had one in second year last year, yeah, and that was my first one because we never had one in first year because of COVID. So yeah.
Well, when you do the next one, let's have fresh, let's have a top tips for OSCEs based on your experiences and where you could have gone wrong, what could have improved, what went well.
Yeah.
It'll be nice to have a little session on that, and I can chime in and give you some, from what I remember, I actually remember some of my OSCEs from the past. I remember one where there was an actor and you had to explain the therapy, periodontal therapy, non-surgical periodontal therapy, and the advantages and disadvantages, and where the students really didn't do as well as they wanted is because they failed to identify the fact that there's going to be recession, just warning the patients that will be recession.
Yeah.
If you've been successful, you're going to get recession. That's a normal part. And so that's a lot of students miss that point. So I guess we can do a little session on OSCEs in the future. I think that'd be good.
Yeah, definitely. And I think a lot of times students will trip up just jargon. And it's such a skill to be able to put that into patient terms, especially something like, perio surgery and recession, and, putting it in layman's terms so that someone understands what's going on can be really quite tricky. So that's a skill definitely that you can work on as well.
It's like sometimes trickier when you are a student, because like in practice, I hope that I'm not using jargon very much. I don't think I am, but because it's just me and the patient, I'm trying to make everything understandable being jargon free. But when you're actually learning the language of dentistry and you're deep in it, and then you're kind of trying to flex. You're trying to flex your knowledge, and you're kind of almost trained to use these words.
Yeah.
You're trying to use all these words of bacteria and everything that you're learning. But actually, when you go into that OSCE, it's complete opposite. You don't want to show off that you want to, all these terms. You actually want to really, for the want of a better word, dumb it down basically for the patient.
Yeah, absolutely. And, we usually have our OSCE as our last exam. So, a few days before you could be writing about the same scenario, but you have to use all of these trigger words and all the words that you've been taught over the last year. And then just to have to switch that off can be really tricky. Because using your jargon with an actor patient, like they will question you, like, what do you mean by that? What do you mean by that? And you will get marked down if you start to confuse your patient or they don't understand what's going on, and then you get flustered, and it's just, it's hard to control those sorts of situations sometimes. Just from a student's perspective, it's really tricky.
It's all about preparation and practice. So in a group of students, so please be doing that, guys. You've got OSCEs coming up, and I think we spoke about this before in the previous episode about mental health and managing the stress. But something like an app called Balance, a daily 5-minute meditation, breathing exercises, really, really important. I remember being crippled by fear during exams and whatnot, especially final year, the closer you get. So completely normal, everything you're going for, all these emotions, all these feelings. I don't want to mention about failure and stuff, but it's just funny that recurring theme I found in interviewing brilliant guests and speaking to great dentists that so many of them actually didn't pass first time round or whatever. And I'm not saying that you should be in the forefront of your mind, but even if that, what seems like the worst thing ever, but I've met so many great dentists who have to repeat second year or third year, and they're absolutely amazing. So firstly, forget about it, right? But should you be affected by this theme, then you're going to be still be okay. So that's the main thing I want to cover there. Emma, let's dive into the main question, the main theme for today. Because we kind of had to, we were super busy last time. We had to cut it short. But there's one really important question when it comes to crowns and indirect restorations, onlays, that kind of stuff. A really great question that you had that I think all students, all dentists actually, young dentists especially, will benefit from.
Yeah, so as a lot of you probably know by now, I've been a nurse for a few years now. And, I've seen so many times lab work comes back, and for whatever reason, it needs to be sent back. And I think I'm quite lucky that I've heard the labs in Glasgow Dental Hospital are very, very good. I don't have much experience with them yet, but all of the clinical staff rave about them, say, oh, you'll miss this when you're out in practice, all the rest of it. But I suppose, are there common challenges that you find during the fitting stage specifically? And even more specific than that, I suppose, what warrants, lab work having to be sent back to the lab versus, yourself, oh, I can fix that chair size, where's that sort of line, I suppose, because as much as I've seen it, lab work needs to be sent back. It's never really been explained to me, it's never had to be. It's not my job at that point. So that's just an interesting one for me as well, just what's going on in your head when something's just not quite right.
Okay, excellent question. Let's tackle it bit by bit. So when the lab work comes back, let's say, so they can make it very specific, it's upper first molar crown. Let's say it's an all ceramic crown, about a traditional shoulder, 1 millimeter all the way around. And the reason we did this crown was it was a root filled molar, and then you prepared it, and then you took some impressions or a scan to lab sent you back this lovely tooth colored crown that you're going to fit. So first thing to do actually is to check it on the model. When you check it on the model, what you're looking for is, are there any major gaps or voids? So where the crown meets the actual prep on the die model, if you're seeing gaps and voids, you got to assess what's going on. Is it perhaps that you're not able to seat the crown all the way on the model? And maybe the issue is not that's an open contact. The issue is that it's not fully seated because the contacts, mesial and distal, are too proud and they're not allowing you to seat the crown all the way. Does that make sense?
Yeah, I think, yeah.
So the crown is too tight. It's not able to go in because the adjacent teeth are not letting it slip through. So that's the first thing to check. So you want to check with floss on the model, see how it is. And if the contacts are tight, we're going to talk about how to adjust that in a moment. But let's assume that there is a degree of an open contact. Well, firstly, before we take a step back, I was always taught, always check that it's the correct lab work for the correct patient.
Yes.
Sounds silly, I know, but you'd be amazed, okay? So make sure it's the correct patient, and correct thing was done, correct tooth, etc., all that kind of stuff. And then you're going to do a quality control on the model. If you notice that the contacts are fine, you're flossing them okay, but there seems to be an open contact, that's a real red flag right there.
Yeah.
Really, it should be nice and sealed. So at that point, you got to think, okay, what is my threshold? Because you know what? Sometimes the lab are doing their best they can with what you've sent them. Sometimes you've sent a preparation and there's been an undercut, or there's been an issue that the lab had to overcome. For example, another issue could be the path of insertion of the crown was very awkward. Because we've got some like rotated and twisted teeth, the lab had to really find out how to insert this crown. Because that path of insertion, it creates an undercut in one area, and therefore now you have to accept the slight open contact in one place. Now, if it's a straightforward crown and nothing should be wrong, it really should be perfect, then fine. But if maybe you got to reevaluate your prep and think, at that point, you got to pick up the phone and maybe take a photo, pick up the phone and say, I'm noticing this. Did you guys struggle? And then you'd be amazed that sometimes you get some feedback that actually, you know what, Emma, we really struggled with this prep. You know, let us know how it goes and what it looks like. We had a look. We noticed this issue as well, but we think it's within limits. So if you see a huge void that your probe can go in, then that's no good. But if it's a small, tiny little gap that cement will fill in and it's pretty much good 90% all the way around, then you might want to then take this to the next stage, which is, okay, let's try it in clinically.
Okay, yeah.
So if it's a huge void, then that's a cause for concern. You need to take a photo, send that photo to the lab, pick up the phone and have a chat with them. If it's a small one, then maybe still talk to the lab, like, I know it's a small void, have a look at the photo and have a chat with them anyway, but then be willing to go through a try-in because it might be a tricky one for the lab to make.
Yeah.
At the try-in, you're going to take off the temporary. So I like to use like these artery forceps or mosquitoes, squeeze the temporary and wiggle it off.
Okay.
You want to clean the actual prep now, because what you don't want is excess temporary cement stopping your crown from seating.
Yes.
And then when you do the try-in, again, you're checking the same things again. Are you able to seat the crown all the way, or is a tight contact hanging you up? So the way I check this clinically is just check with floss. I'll get my nurse to hold the crown, with her finger. Okay. My nurse is a female, so her, but it could be a male nurse. So the crown is now held in place with finger. I will floss myself and just check, is there a nice click? We don't want open contacts, and we don't want something that's so tight that the floss is tearing. Now, when you were nursing, how involved were you in the crown fit appointment?
Not very. No, not really. I would mix the cement and that's about it. There's a few practices I've worked in where I would be the one to put the cement in the crown whilst the clinician is holding it. But that's about it, really. That's about it.
Okay, so the biggest mistake, I remember fitting a crown when I was like 1 or 2 years qualified, and the cement escaped. I wasn't quick enough in removing the cement. Okay. And then now the patient was left with a blocked contact because the cement kind of went in that zone, and now the floss won't go through. And so the biggest takeaway I had about this was actually in hospital. I was a DCT, and the biggest learning I had there is that when you're doing a crown, when you're cementing a crown, it's not a one-person procedure. It's a teamwork procedure. And then really the nurse should be heavily involved. And so the way we do it is, once I put the cement in, once I've put the crown on, and I've got the patient, let's say, bite on a cotton roll to fully seated all the way. Yeah. At that point, it's not like I'm doing everything myself. At this point, either the nurse is flossing or I'm flossing, and one of us holding the crown. Typically, the nurse is holding the crown with her finger, and I'm going to floss, basically. So that is much easier and better than me trying to hold it and then floss it at the same time, or just floss it, and then the crown could be shaking and could not be stable, for example. Yeah. So in that case, we're going to check how it's flossing. So remember, still at the try-in stage, we're checking how it's flossing. And if it's flossing well, great. Now, under magnification and lighting, I'm going to check the buccal. I'm going to check the palatal. I'm going to check my probe. Okay. And then interproximally, sometimes if you just really get the right angle, you can see interproximally. Sometimes you can use a probe to suppress the papilla. Okay. And blow some air and really see that mesial and distal margin. And if it's looking sealed all the way, happy day. So you've got a nice contact that flosses, and you've got a good seal all the way around. If you have a doubt, or if you see an open contact, reassess the contacts, make sure the contacts are good. But now if you see an open area where there's a void, at that point, you got to decide, okay, is it within a threshold? Is it for the reasons that we talked about earlier? Or really, does this need to be rejected? I reject probably, for this kind of a reason, 1 in 30 crowns. Okay. What's been your experience from nursing? How often have you seen a crown been rejected?
I don't even know that I could put a number on it, Jazz. Not hugely common though. Probably quite similar to your own experience. Yeah, quite similar maybe.
Yeah. So it's only because I'm quite strict in my quality control. So if I see
Yeah,
something
okay.
like that, I mean, you could at this point take a bite wing radiograph, right? And see, okay, how does it look on a bite wing? Sometimes it's very obvious on a bite wing as well that it's open. So if you have a doubt, you could take a bite wing at this stage.
Yeah.
You really want the margin sealed all the way. So assuming now the contact's good and it's sealed all the way, what are the other reasons why it could get rejected? Okay, for an upper first molar, aesthetics, you'd be amazed. Okay, so usually aesthetics shouldn't be that important, but for some patients it is.
Yeah.
And so you could show the patient a mirror, but even before you show the patient a mirror, you got to look at it and decide, okay, we want for a white crown for a reason, because obviously it's got to be tooth colored. And if you think it looks good, if you as the clinician feels like it looks good and you are proud enough to cement it, great, that's a great sign. If you think something's not right and this looks really bad, then don't be the guy who shows the patient a mirror and the patient goes, yeah, it's fine, because that could, really bite you in the backside one day. The patient comes back saying, oh, I smiled really big and actually it's a bit yellow. You don't have a leg to stand on because you notice, actually this looks really out of place, right? So you yourself have to be happy with it.
Yeah.
Once you're happy with it, you show the patient. What you don't want to say is, what do you think? Because then what you're doing is you're opening yourself up to criticism. Actually this and that. It's okay. Hey, look how nicely it matches the adjacent teeth. I'm quite happy with this. Just checking. So I just want to show you before I glue it in.
Yeah.
And like, oh, okay, all right. Thank you so much. Okay, that's good. So aesthetics could be a reason that it gets rejected. Very rare in a posterior situation, basically. The other one is now occlusion.
Okay.
When the occlusion is proud, you can adjust it, right? If it's like massively proud, like huge, and you're running short of time, then you may wish to record a bite restoration, send the crown back, and get the lab to adjust the occlusion in. Very rarely we have to do that, basically, okay? The more significant issue is the other way, whereby it's completely shy of the bite.
Right, okay.
Like it's massively shy, so there's no bite on it at all. And so you might be thinking, okay, is that really important, Jazz? You might be saying, is that really important? Well, on someone who's got 32 teeth and all the teeth hitting together nicely, okay, one tooth that's not perfect in the bite is not going to be the end of the world.
Yeah.
The patient will likely adapt. There'll be some overruption and rotation, that kind of stuff. That's not ideal. But in that case, the patient's going to live. It's all right. But if you've got like implants around the arch, which you don't want loaded and clench, if you've got a patient who's periodontally susceptible, maybe they've got some mobility, then that kind of patient maybe is kind of important, right? And so it may be that, you remember we talked about shim stock foil, that 8 micron foil?
Yeah.
It may be that it's not holding shim, but we've got to now figure out, okay, at what's our threshold level? At what point do we reject and what point do we accept? And there's no hard and fast rule here. With me, if it's a patient who's got generally an okay occlusion, I want the occlusion to be within 100 microns. So that's 0.1 millimeters, within 0.1 millimeters. This is on someone whose occlusion is pretty good. If it's more than 0.1 millimeter out, so for example, I get 100 micron articulating paper, get the patient to bite together, there is no smudge, there is no ink. Only when I get the 200 micron paper do I see a mark on it that really is out of the bite.
Yeah.
In that case, you could send it back and take a photo and send a bite reg and say, this is not met my expectations. Okay, so that happens very rarely. However, in someone who actually this is a strategic tooth and it really needs to be in the bite, it needs to be well in the bite, okay, your threshold might change. It now might be 20 microns, basically. Okay. If you try when the shim stock is pulling, but when you try with your 25 micron paper, it's biting, okay, that's an okay threshold. It's going to just do some minor adjustments and it should be okay. So it's something that we don't think about, and I didn't think about it for many years until after qualifying. So hopefully there's a nugget in there for someone who might be listening or watching to this. Have you ever thought about that in terms of the occlusal tolerance of a crown fit?
Not really, but what you're saying is making sense. And I think quite commonly as students, if we see a blue dot after using your articulating paper, you just want to take it away. But there's so much more to it than that. And I think what has always stuck with me, one of your first episodes I ever sort of made the notes for was checking the occlusion beforehand. If you have the luxury of being able to do that, then that's definitely stuck, because you don't just want to take something out of the bite if you don't have to, if that's not the case. So that's something that's always stuck with me. And I think, as students, we just want to grind it all away until there's no dots that you can see at all, but that's just not what you want to do, is it?
Yeah, that level of precision is not great. And so when you're a dental student, when you're, sometimes young dentists, some dentists might be watching, listening to this, you might be 20, 30 years qualified, you might be following this philosophy called GABS. Do you know about the GABS occlusal philosophy? No,
I don't think I do. No.
Gabs is grind all blue spots philosophy. So
Okay.
there's no precision there. So I wouldn't recommend it. And it's something that we do. And then the patient says, "Oh yeah, that feels great." Right?
Yeah.
Okay. And then so obviously it feels great, right? But actually that you're not really serving your patient real well, because if every time the patient comes in and they have a new crown restoration, it's out of the bite, most people adapt. But sometimes people don't adapt very well.
Yeah.
For example, if everyone just adapted, everyone's bite just adapted, you'd never see a patient with an anterior open bite because their teeth would just compensatory up, right? That would exist. But some people don't have that adaptation capacity. So I would suggest a degree of occlusal quality control.
Yeah.
I'm not saying we have to be perfect, because no one's perfect. No one's going to fit their crown. It's going to be shim hold every single tooth every time. But to recognize that patient where it's absolutely crucial, and recognize the patient that, okay, it's not crucial, but it's a little bit shy, but it's not so shy that I can't sleep at night.
Yeah.
So aesthetics, seal, and occlusion. Those are the main things, basically. In terms of checking the contacts, once again, I've talked about this on the podcast, but in case a student hasn't seen it, here's an interesting one. Have you fit a crown yet, Emma?
No, not yet.
Okay. So this is really, really important. Like when you come, so this happened to me as a young dentist. I'm trying to put the crown on, and I've said, oh my goodness, there's a huge open margin here. But it wasn't an open margin. It's just because the crown didn't see all the way, because the contacts were too proud. And at that time, I didn't really know how best to check that. And I remember a consultant coming over and then putting on a miller's forceps the articulating paper in between the prep and the adjacent tooth. So in between, like really like sausage hands, like trying to get in, and then trying to seat the crown with the other hand. It's very claustrophobic, very messy.
Yeah.
So the better way of doing it is keep the crown in place. Get the nurse to put a finger on the crown so it's now stable. The patient's not going to swallow it.
Yeah.
You get some articulating paper and you color in your floss, i.e. you pinch the floss with the articulating paper and you drag it. Now you got white floss, and suddenly the floss is red, and then it's white again, okay? That red ink on the floss, when you floss that through the crown, it's going to make a red smudge where it's too tight.
Okay.
That's where you adjust until you get the perfect flossing and it's seating all the way.
That's good. I've never seen anyone do that. Color in your floss. That's a good one, yeah.
As a nurse, if you've seen dentists do the traditional way of checking with their fingers, it's very claustrophobic. It's a terrible way of doing it. So this was taught to me by a prosthodontist, Ricky Bhopal, and I always credit him for this. Is the best way to do it.
Yeah.
And actually, when I shared this on Protrusive, everyone who does this, like, mind blown. Like, why wasn't this ever taught to me before? So top tip there. So just to summarize the episode. There will come a time where you need to reject lab work. We talk about dentures another time and all sorts of things. But talking about a single crown, aesthetics is one reason, and make sure you're happy with it. Is the seal not good? And if the seal's not good, then that's a big fail. If it's like there was a tricky prep and it's like a tiny bit, but you can't get your probe fully in, you then have to put some faith in your cement to help you out here and seal that. And then occlusion. If the occlusion's really, really shy, then that is a problem as well in some patients.
Yeah, that makes sense. And I think as well, a huge takeaway for me, you're always told, make friends with your lab technicians, and that's so true. And, just picking up the phone and talking to them can solve so many issues, just having a chat, getting that feedback as well. They're not scary, they're not going to bite you or anything, but communication is a huge one with the labs, and keeping them on your side, because then they'll do you a favour when you need it.
Absolutely. And I would encourage everyone to have a good relationship with their lab, and also when you qualify and stuff, and to maintain that and to ask for feedback. It's really scary, but if you say, be brutally honest, if you write in your prescription form, be brutally honest about my prep, okay, they will be. And then they will feel comfortable having that relationship with you, and that's a really great place to be. If you can visit your lab one day as well, it's a really good thing to do, to visit your lab. Okay, that's a good thing to do as well. See their workflows and develop a really open relationship with your lab. If you can WhatsApp your lab, voice notes and stuff, and discuss cases, that's something I do, works really well. So I think you've summarized that really well, having a really good relationship with your lab. Now, here's a really interesting thing, right? Dentists, especially when you're newly qualified, we see the lab technician as this like guru, this oracle, right? And they're like, they know so much, and I'm the insufficient one, and oh my God, my prep is not good enough for this guru. Okay. Now, funny enough, I'm speaking to lab technicians. Okay, they are seeing us as the guru. Like, oh my God, it's the dentist. The dentist knows what they want, and I'm just following. And what if I'm not good enough? And so we're looking at each other as like, you're the guru, basically. Actually, we're both the gurus. Okay, we both need to work together. Okay, and we have so much to learn from technicians. and technicians can learn something from us as well, for sure. So sometimes when I used to write that, okay, I've trained my technician to do this type of technique, people were like, oh, really? You can train a technician? You totally can. And a technician can train you as well. So have that symbiotic relationship. Has anything been left unclear now in terms of when to reject a standard crown? And any questions your student mind can come up with now as you've read about this procedure and when you eventually first come to do it?
Not in particular. I think you've covered things quite well. Loads of good tips and tricks, especially about the floss. I like that one. I'll bring that into dental school one day. But no, really, really good tips and tricks. And I think as well, just assessing each patient individually, such a common thing in dentistry, like, oh, it depends, but it really, really does. It's so case dependent. And as well, when you're saying about, you know, utilising your nurse, I think being a nurse myself, it makes your work so much more interesting when the dentist will use you to your full capacity. Like, get me to put my finger on there and get me to floss these contacts, because, you know, I've watched too many dentists struggle, and it's just you know, I've got an extra 2 hands here. If you need them, then they're yours.
Absolutely.
Like, just, you know, and it makes work so much more fun as well. So
brilliant,
definitely.
brilliant. So important to involve your nurse, and you'll have much less likely to have that scenario where cement is now blocked the contact, like it happened to me. So that's a really great point there. There's one more thing I was going to say. Actually, we haven't really talked about cementing and stuff, so maybe we'll talk about cementing another day. But you're right that getting the nurse involved is another great tip. No, here's my thing I remembered. Okay, this is really important, Emma, for all students who've got to this point and all dentists got to this point. Okay. When you are at dental school, especially, okay, I'm teaching you the shortcuts and the tricks that I've learned now because of failure and trial and tribulations and errors and stuff, right? So I'm able, you know, you're able to stand on the shoulders of giants and not have to go through all the mistakes and tears and stuff, right? You're able to really leverage this, and you're in a great. So this is a beautiful thing about dentistry nowadays is that we can pick up these tips before we're very isolated. However, you got to be really careful in dental school, right? Because your tutor wants you to do it a certain way. So my suggestion is learn the way they're teaching you to do it. Learn the way and learn it well. So if they tell you, okay, this is how you check a contact, you get the red paper and they show you this atrocious way of doing it, please do it. Be good at doing this atrocious way. Only then will you appreciate the way I'm showing you. Okay, so please, what I don't want it to do is all these hundreds of generation of students now, every time the tutor shows us something, it's like, nah, Jazz taught me a better way. Let me show you, tutor, how to. Well, we don't want to create that culture. You must be a learner and have some humility and be like, I'm going to do it this way because this is the way I'm taught. But in the back of your mind, it's like, I know another way. Okay, and then try it. Okay, and so please don't be also, you know, don't be a smart aleck with your tutors, guys. Okay, and then I'll get a bad rep with the tutors.
But also as well, like as a student, half of the time, you know, these clinical staff, you know, they can be the ones writing the exam questions and writing the marking scheme. So yeah, definitely listen to what they have to say as well. But you know, if I would know loads of clinical staff that I would feel comfortable saying, oh, that's interesting. This is another way I've heard of doing things. And they're always so open to, you know, new techniques and having these conversations.
Brilliant.
They like you to be able to you know, do your own research and have your own back about why you want to do things a certain way. But yeah, they're the ones writing the
There are some tutors
exams.
like that, and God bless them. So but not everyone's like that. So just be tread carefully. Okay, so Emma, what notes have you got as part of the student revision notes that you're giving away in terms of Emma's famous notes?
So this month we'll go back to first year and we're going to do a bit of microbiology. It is quite theory heavy, very examinable, especially in first year. But you know, these things come up time and time again. And as you move on to second year, third year, fourth and fifth year, you just build upon it more and more, and it gets more specific to specific aspects of dentistry. So it's definitely something that you need to have solidified from your first year going forward. So we'll do a bit of microbiology.
Is this have you got like the microbiology of caryology, like caries, that kind of stuff?
Yeah, I need to dig out my first year books actually. But
so
yeah,
the caries process very important, and then also infections, different bacteria involve anaerobes and that kind of stuff. You got that right?
Yeah. Well, I'll be in there.
Okay, every examinable facet of microbiology will be in there. So we look forward to sharing that with all those on Protrusive Guidance in the student section. All the instructions about it is on Protrusive Guidance. So Emma, thanks again, and have a lovely week.
Thank you.
Well, there we have it, guys. Thank you so much for listening all the way to the end. Hope you found some value from that. Please let me know if you did. The best place to let me know is on Protrusive Guidance. Our app is on iOS, Android, even the laptop when you hit www.protrusive.app. If you're a student, you get access to the Protrusive student notes, including for this episode, and the Protrusive Vault. You just have to email your proof to student@protrusive.co.uk. The community otherwise is completely free to join. So if you haven't joined Protrusive Guidance yet, what are you waiting for? I want to thank Emma, our Protrusive student again, and the whole team for this series. That's Erica, our producer, Jan behind the scenes with video, Chriselle and Nav, who often do the premium notes. A shout out to Rakesh, who's just qualified as a dentist, God bless him. Such an exciting time. And of course, our CPD queen, Marie. Please do share this episode if you think someone would benefit from it. I'll catch you same time, same place next week. Bye for now.